All right, well, thanks to you all again. And yeah, we'll dive right into refractory heartburn. All right, same disclosures. Uh, so gastroesophageal reflux disease, or GERD, and we're all familiar with the Montreal consensus definition. And this can manifest as a variety of esophageal syndromes related to either objective injury to the esophagus and or symptoms only, which occurs in the context of non-erosive GERD. And these syndromes can involve typical symptoms or extraesophageal syndromes. And now in 2021, proton pump inhibitors, or PPI, remain the most common empiric and or first-line treatment for frequent reflux symptoms. However, PPI refractory symptoms are exceptionally common, and 30 to 50% of patients are unsatisfied with symptom control. And endoscopy is the first-line diagnostic test and remains an important essential test to evaluate for Barrett's or erosive esophagitis. And you can also assess for other important factors such as hiatal hernia, as well as excluding alternative diagnoses such as EOE. But the yield of endoscopy, especially when performed in a patient that is actively being treated with PPI, is quite low, and most patients will have a normal EGD. Also noted is that treatment response can vary by the GERD manifestation. And so in a review of randomized controlled trial data, we can see that while PPIs are incredibly effective at healing esophagitis, the subjective response to heartburn is worse. And among other syndromes and other manifestations of GERD, there's even a lower response to acid suppressive therapy with PPI. So this brings up the issue related to the mechanism involved to GERD as they're related to these bothersome complications and or symptoms. Certainly, GERD syndromes that manifest with esophageal injury will be significantly, if not predominantly, associated with the degree of reflux burden. But in the subjective GERD syndromes, the patient perception of the esophageal stimuli, and this may be either with pathologic or physiologic stimuli, can have a major impact on the degree of symptom manifestation, and thus the ultimate patient satisfaction with the treatment. However, treatment of PPI non-responsive symptoms likely requires targeting of this underlying mechanism that's contributing to the symptoms. And this will incorporate identification and recognition of the multiple features that can play a role in this balance between reflux burden and symptom perception related to ongoing symptoms. So if an initial evaluation demonstrates significant anatomic abnormality, such as a large hiatal hernia, in those scenarios, surgical repair to address the hernia may be needed. However, if this initial evaluation suggests that reflux burden is minimal, considering other factors such as hypersensitivity, anxiety, and hypervigilance may have a larger impact on the perception of symptoms and improvements in patient satisfaction. Because of course, we recognize that there is a spectrum of these reflux disease states. So this conceptual model was proposed from along with the Rome criteria for functional esophageal disorders. And this reflects the overlap and interplay of reflux burden with esophageal hypersensitivity in these esophageal reflux-like syndromes. Also notably, this highlights the value of esophageal pH monitoring, as endoscopy is only going to be diagnostic in this proportion of patients with erosive esophagitis. Whereas with pH monitoring, this helps objectively characterize a patient's reflux phenotype, and this will directly impact the expected response to treatments. And therefore, the initial step in evaluation of treatment refractory symptoms is to answer the question as to whether or not pathologic GERD is actually present. If GERD is not present, GERD is unlikely the cause of symptoms, and ongoing treatment for GERD is not needed. If GERD is present, then the chance that refractory symptoms will respond to escalating to treatment remains a possibility. And so with ambulatory reflux monitoring, esophageal pH testing is the way to answer this question. And often the question does come back to what modality to choose and how to perform the test. And so there are pros and cons to using wireless pH monitoring or catheter-based pH impedance monitoring. And the choice can be made by weighing these pros and cons that come with each modality, and also tailoring the application to the clinical scenario. So while wireless pH testing is typically placed at the time of sedated endoscopy, it does offer the advantages of not requiring a transnasal catheter, and it's thus better tolerated by patients and can provide the prolonged monitoring periods of 48 to 96 hours. And this allows for evaluation of day-to-day reflex variability. Additionally, the lack of the catheter allows for patient activity and eating, and this may provide a more real-life interpretation to help assess symptom burden. pH impedance, however, typically does not require sedation for placement, and additionally, its dual channel capabilities allows for detection of weak or non-acid reflux, evaluation of proximal extent of reflux, detection of air and belching, and also some other novel metrics such as the basal impedance, which are certainly promising in assessing acid reflux, and particularly with PPI refractory symptoms. So overall, this often depends on the clinical scenario as to which modality to choose, though often if GERD is not previously proven, and that means a lack of previously observed advanced esophagitis, Barrett's esophagus, or peptic stricture, then there's a low pretest probability for GERD, and pH testing off PPI, often with a prolonged study, may be the preferred method. But if GERD was previously proven, then pH impedance testing on PPI, and typically on high dose PPI, may be beneficial to help determine the underlying cause of symptoms. And then interpretation applies that the total acid exposure time, as well as the symptom reflux association measures, to phenotype the esophageal reflux state. For acid exposure time, less than 4 is typically applied as normal and greater than 6 as pathologic. And this also leaves a borderline or inconclusive range in the middle. But overall, applying these things together can help interpret whether or not patients do have normal acid exposure time, in which case the diagnosis is either functional or a non-GERD etiology, or if they do have pathologic GERD, and thus case GERD treatment may be warranted, or even if there's a possible scenario that people have had proven GERD, there can be assessed for overlap syndromes, recognizing that GERD and functional heartburn, as well as GERD and reflux hypersensitivity, can exist in a similar patient. We recently studied the clinical outcomes associated with the prolonged 96-hour wireless ambulatory pH testing. And this, of course, was performed off of PPI and in patients with PPI non-responsive symptoms. And the ability to remain off of PPI was applied as the clinical outcome. While this makes intuitive sense, only 20% of patients with 2 or more days of abnormal acid exposure were actually able to remain off of PPI. Patients with abnormal acid exposure need maintenance treatment for GERD and likely will require escalation of treatment beyond the treatment they were initially not responding to. But on the other hand, having 0 4 days positive was predictive of being able to discontinue PPI. And over 2/3 of these patients were able to stay off PPI, and the remainder likely could be counseled that they could stop PPI, and evaluation for an alternate cause could be pursued. Now we think about alternate causes. This is where manometry does play a role in the evaluation of GERD. And manometry with or without impedance can be useful to help evaluate for alternative or contributing conditions. Although rare, achalasia can present predominantly with heartburn. And obviously this is something that detecting will alter a management plan. Though in addition, assessing motility and identifying hypomotility states may have implication for both assessing an underlying mechanism related to reflux, but also may have implications for directing candidacy for anti-reflux surgery. Also worth briefly mentioning is utilizing postprandial high-resolution impedance manometry studies to objectively diagnose rumination or supragastric belching, as these typically subconscious behavioral disorders can lead to reflux. And though these often will clinically manifest more with refractory regurgitation or belching, as opposed to just pure heartburn, as is the focus of this talk. Supragastric belching can also be identified on pH impedance testing, represented here by the appearance of air being infused and then being immediately eructated with this supragastric belch pattern. And now if GERD is not identified as the cause of ongoing symptoms, this is where treatment shifts to the perceptive or anxiety components related to these ongoing symptoms. And with functional esophageal symptoms, pharmacologic treatment often is to use treatments that target neuromodulation. Also important to note is that use of antidepressants, which is the most commonly used medications here, is off-label use. And these are commonly prescribed for visceral pain across the GI tract, and as well for modulation of chest pain of esophageal origin. The mechanism of action for this therapeutical benefit is generally unknown, and these agents have both central and peripheral activity and have multiple receptor targets. Among the antidepressants, though, tricyclic antidepressants are the best studied, and there are multiple studies that do demonstrate benefit with these other agents. Though it is worth noting that all of the agents listed here really have their predominant benefits listed for treatment of functional chest pain syndromes. And so the assumption of a shared mechanistic process with functional heartburn or reflux hypersensitivity supports some of the use across the other functional esophageal syndromes. One study to highlight is a study that did specifically look at treatment of patients with functional heartburn and esophageal hypersensitivity in a placebo-controlled randomized controlled trial of using the tricyclic antidepressant imipramine. And the note of this study, using a subjective outcome of a 50% improvement in a GERD symptom score, 40% of patients met the primary outcome with meeting the symptom endpoint using imipramine. However, this was no difference with placebo. So a very high response rate, both in the placebo as well as the treatment arm of this study, and showing the lack of a benefit, at least a different benefit, using imipramine. Another potential role of therapy for patients with functional syndromes are behavioral therapies, and cognitive behavioral therapy can be very beneficial. And one such behavioral therapy actually is diaphragmatic breathing. And diaphragmatic breathing is a particularly appealing option, and this is noted to be that this is the treatment for rumination syndrome if that's suspected or identified. And diaphragmatic breathing can have some role as a treatment for supragastric belching, though frankly not quite as reliably effective. And this technique is fairly easy, and this can be instructed during a clinic visit, and involves instructing patients to expand the abdomen, to have the abdomen come out during inspiration, and then having slow expiration, during which the abdomen will move in, and having the patient place their hand, one hand on the abdomen and the other hand on the chest, can help the patient practice this maneuver. This is something that can be applied postprandially or just when symptoms occur, and often can be done at 10 to 30-minute intervals. Sometimes I'll even direct patients to watch instructional videos on YouTube for self-practice, or often use a behavioral therapist for ongoing instruction if needed. And interestingly, diaphragmatic breathing may actually also have a role in treating objective pathologic GERD. And this was recently demonstrated by a sham-controlled trial of diaphragmatic breathing that enrolled 23 patients that had predominantly upright acid exposure on pH testing that was performed off of PPI. Noted that this used the active arm of this study, looking from day 1 to day 2, and actually showed reductions in both acid exposure as well as the number of reflux events when practicing diaphragmatic breathing for 30 minutes after meals. And this had no change in the sham arm, which was just to have a patient listen to music. So sending patients for musical therapy, probably not effective in acid reflux, though may have some other benefits for quality of life. All right, and finally, it's another thing to use and potentially consider for patients that do have functional syndromes, but is gut-directed hypnotherapy. This is another appealing and potentially effective option. However, empiric data remains fairly limited. This reflects a small study from Northwestern that showed that patients that had functional heartburn and underwent 7 weekly sessions of gut-directed hypnotherapy actually had improvement in quality of life scores. They had actually improvement in visceral anxiety, and they had reduction in a catastrophizing measure. And all patients, all 7 of these patients, or all 11 of patients, excuse me, at the end of the therapy did report that their symptoms were substantially improved or slightly improved. So if available, this is a nice option with low risk. However, now to return to treatment for when GERD is present. And first off, beyond there's optimization of lifestyle-related reflux management strategies. Weight loss in particular can have major benefits, as well as avoiding late meals, sleeping positionally, so having the head of the bed elevated 6 to 10 inches can be very beneficial. But otherwise, treatment options often can actually begin with trying to optimize the primary mode of therapy using PPIs, because it's worth wondering sometimes why the initial PPI was ineffective. And this recognizes that not all PPIs are created equal. PPI adherence is an issue, and mostly related to the fact that PPIs are most effective if they are taken 30 to 60 minutes prior to a meal to help optimize the availability for active proton pumps for acid inhibition. Dexlansoprazole or omeprazole bicarbonate formulation can actually help circumvent this PPI caveat. Also worth noting, though, is that there are differences in potency across the PPIs. And these are based on studies that measured gastric pH suppression. But most notably is that pantoprazole in particular is several-fold less potent than the other PPIs. And I do see often that patients are on this medication without a responsive therapy, and a change to a different PPI can provide added improvements. Other things to consider: PPI absorption or lack thereof may play a role. This may be particularly relevant in patients who have bypass surgery or have severely delayed gastric emptying. Dexlansoprazole, or again, the omeprazole bicarb formulation, can again be useful in these scenarios. And finally, PPI hypermetabolic effects are worth considering, and sometimes a change to a different PPI can yield beneficial results. However, that's ineffective. Often other add-on therapies are considered, and H2 receptor antagonists remain an appealing option in certain scenarios. These can be particularly useful for helping to prevent nocturnal acid breakthrough, and it's by demonstrated in this study. However, there is a limitation in using the H2RAs on a long-term basis, as tachyphylaxis or tolerance can make them less effective after 1 to 2 weeks of continual therapy. However, there still may be a role for the add-on use for on-demand or even short-term use for some patients. Another potential target for PPI add-on therapy in those who do have breakthrough GERD is alginate-containing antacids. The alginate creates a raft, and this can help directly displace gastric contents at the gastric acid pocket near the EGJ. And studies that have looked at using this in addition to PPI have demonstrated, albeit somewhat inconsistently, that this can relieve symptoms. And in this study, there's a greater reduction in a heartburn symptom score with alginate compared with placebo. Because of the anatomic effects potentially related to hiatal hernia, this may be particularly appealing in those scenarios. Though again, it's worth noting some results of some inconsistent results of effectiveness across studies. And while there are other medications and strategies available, it's of course worth mentioning that anti-reflux surgery is certainly an option to sometimes consider for treatment of confirmed GERD. As mentioned, if there's a large hiatal hernia present, anatomic correction with surgery may be worth earlier consideration. And additionally, worth noting here, this list isn't meant to be all-inclusive for the different anti-reflux surgical interventions or approaches, and there are others available. Though there is one study in particular that is worth discussing that was recently published. And this was in the New England Journal of Medicine, and in an extensive multi-center effort among Veterans Affairs hospitals across the United States, patients that specifically had heartburn that was refractory to PPI. So certainly the cohort focus of this talk were specifically studied. They enrolled patients that did not have severe reflux esophagitis. They didn't have a major motor disorder on manometry, and they all had PPI refractory GERD defined on 24-hour pH impedance testing as having either abnormal acid exposure or positive symptom reflux association using the SAP as the measure. Eligible enrolled patients were then randomized to laparoscopic Nissen fundoplication versus PPI therapy with omeprazole 20 milligrams BID plus baclofen plus decipromine in the active treatment arm. This was versus another control treatment arm with BID PPI plus 2 placebos to control for the baclofen and decipromine. So again, a major effort and a major undertaking to look at this important patient population. And a very interesting aspect of this study was that the selectiveness required for randomization and study inclusion. And so of 366 patients enrolled, only 78 were actually eligible for randomization. Of these excluded, 24% were unwilling or unable to complete the pre-randomization procedures. 15% actually had symptom improvement during a monitoring PPI run-in trial where patients were observed doing their BID PPI correctly. And after testing, 34% of this cohort had functional heartburn based on the on PPI pH impedance testing. And overall then, this study fell short of its recruitment goal, and thus it was ultimately underpowered. But with that limitation in mind, the rigor of the study is certainly worth noting. And using, again, improvement of 50% or more in a GERD health-related quality of life score at 1 year after randomization of the study, they show that in this highly selective groups of patients with PPI refractory heartburn, Nissen fundoplication did have a greater rate of positive outcomes in the intention to treat analysis, with 67% in the surgery group meeting the symptomatic endpoint, compared with 28% in the active treatment arm and 12% in the control arm. Recognizing here that each of these arms is only 25 to 27 patients in size. There was also a small signal in this study that fundoplication may have been more effective than medical management for the subgroups of patients that were specifically identified with reflux hypersensitivity. However, the sample sizes become very limited at this point, and thus there's definitely some caution in applying that finding. But I think the main takeaway here is that in this very highly selected cohort of patients, surgery can be effective at relieving symptoms, though again, recognizing this was effective 2/3 of the time, leaving 1/3 of the patients still likely unsatisfied with their treatment. So with that, I'll conclude and just thinking about treatment of refractory heartburn, which is very common, but importantly to recognize that not all heartburn is related to GERD, and thus identification of the mechanisms of PPI refractory symptoms is essential to help direct treatment. Symptoms not related to GERD may be treated with treatments that target hypersensitivity and perception. This may include antidepressants and behavioral therapy. And symptoms in the presence of GERD can focus on optimization of acid and reflux suppression, and anti-reflux surgery remains an effective option in carefully selected patients. So that again, I'll thank you all for your attention.